Hey, good morning. This is Steve Stites, Chief Medical Officer at the University of Kansas Health System, broadcasting live with you from the Dolph Simons Family Studio. We're sorry a little late, just a little trouble getting the warp drive started, also known as the internet, but we're back online. Scotty came through. Actually, that's really Cliff and Anthony, but we made it through just like Scotty would have brought us through. We got the warp drive going. Yes, it's another Star Trek reference to start the show. Isn't that spectacular? We're here this morning. We got a pretty cool lineup. We got a lot to talk about with some really interesting guests because the conversation is going to center on the silver lining of this pandemic, the success of telehealth in improving and keeping people healthy during a really difficult time. And we have a number of experts who are going to help us with that. But first, Hawkeye.
Yeah, I mean, to be fair, Cliff was just sitting there back there saying, I can't do it, Cutman.
Yeah, you did it.
So we had to give him a little bit of pressure, but
another mark.
They got it going.
There we go.
Numbers, still pretty good. I think, again, in the Kansas City area, we've seen a little bit increased numbers yesterday. But here at the health system, we have 9 active inpatients with 3 in the ICU, 1 on the ventilator, still 17 in the recovery period.
But down from 11. Good trend.
Yeah. So I think, again, we're pretty content with this number right now, considering what we're hearing about Europe, some other states in the United States with increased number of cases as well. Hayes has 3 patients, 2 active infections and 1 in recovery.
So, really, those are much better numbers overall. I'm anxious to watch what happens in the next few weeks after spring break. A lot of reports about what's going on in Florida and other places without as much of a masking culture. It's really going to be a test on where we are on the vaccine as people where we are on the COVID crisis as people come back from vacations in places where there's been a lot of gathering, Hawk.
Yeah, I think one of the headlines we saw was too many people, not enough masks. And we know, we saw and we remember pictures from last spring break, and again, it would be good to be able to get back to doing those things and getting together with friends and family, but right now it still remains pretty dangerous. We still need more supply of vaccines to get into the arms as well.
All right, so I want to start with our Jason Grenstrom. Jason is the executive director of the Continuum Care here. Also, we'll be talking with Dr. Philip Newland, who's the chief medical officer for Ascension Medical Group Via Christi, and Dr. Keith Sale, our vice president of ambulatory medicine. This is a really terrific group of folks with lots of content expertise. I'm going to start that conversation with Jason. You and many others have helped us to establish our telehealth here at the health system, including our ambulatory leadership with Keith Sale, Russ Ray, and Kim Dixon. But let's break it down a little bit. How and why did the pandemic help the telemedicine movement explode, Jason?
Good morning, Dr. Stites. Thank you.
Good morning.
Yeah. The public health emergency, as we know, was enacted by former President Donald Trump and also here in the state by Governor Laura Kelly. And basically what the public health emergency did was it eliminated a lot of barriers that were in place prior to the public health emergency was put in place for patients being able to see physicians via telehealth. Those barriers included things of where you couldn't actually see a patient in their home, the comfort and safety of their home. Patients actually had to travel to a medical facility in order to see someone through video. And so when that was enacted, a lot of things changed. Funding was released through CMS to allow for reimbursement for a patient to be seen at home. And so those are some of the things that I'm actually going to show you in some of the slides we got coming up that really impacted the healthcare system as well as other hospitals across the nation in being able to see patients that otherwise they were not able to see. I brought some slides with me that I'd like to bring up. So if we could bring up the first slide, you can see here the graph shows you from January of last year, 2020, up to February of just last month. You can see 2 lines. The top orange line shows you the number of in-person doctor visits, and the bottom blue line shows you the number of video visits. As 2020 started, we saw our typical number of about 100 telehealth patients per month. And remember, we were under the rules before the PHE was enacted. You can see in March, as COVID-19 numbers started growing across the country, many people started canceling their doctor's appointments, and for a number of reasons, most out of fear of public health and possibly going out into public, and possibly getting COVID-19. You can notice how the bottom line is picked up as many doctors started seeing patients through video. And at the time went on, we saw about 33,000 patients alone in the month of April. And that represented about 22,000% increase in volume. Today, we see on average of about 1,000 patients per day. The demand is high for so many reasons. Patients have recognized that telehealth is a great way to see their doctor for many reasons which don't require going to the office. And now many patients are asking that we set up their appointment to see their provider through telehealth instead of actually going into the office. So that graph is a pretty powerful graph. If we want to move over to slide 2. We also can see here represented are so many people wanting to see their doctor. We opened up our urgent care to on-demand video telehealth. This means patients could go online and through video see one of our amazing providers within minutes for many different health issues and concerns. The graph shows the demand and how it has grown since we opened up video urgent care in June of last year. Want to move over to the next slide. We can see a snapshot between April and September of last year, which shows you all the places we've seen patients. The red dots indicate where we saw patients through video. And as you can see, we have seen at least one person in every county of the state of Kansas and in more than half of the state of Missouri. It's pretty amazing. If you want to go over to the next slide, I really like this slide. Through the CARES Act, federal dollars were made available to each state to create grants to help during the pandemic. And Kansas created 2 different grants. The first one, called the Strengthening People and Revitalizing Kansas, also known as SPARK, and the other grant, which was called the Connectivity Emergency Response Grant, otherwise known as CERG, to help states fund as much needed internet and connectivity across rural areas. The University of Kansas Health System has always strived to keep care local when possible. And what that meant is that we want each person living wherever they are to be able to know that they can get great care right where they live, from doctors and nurses in their community. And we knew the resources necessary to get these grant dollars was going to be very difficult for those community hospitals. And that's why we applied to these grants and ended up being awarded some of them. We were awarded just under $3 million, and our health system also added funds to the grant. And so some of the really cool things that came out of that grant, if we could move over to the next slide. This slide shows you what was accomplished with those funds. And remember, no funds from the grants went to our hospital here in Kansas City. And you can see we were able to get 22 rural hospitals with the necessary equipment and high-speed internet connection in order for those hospitals and doctors to function better and to also see their patients using telehealth. Another benefit to these hospitals was of having high-speed internet was that they are now able to connect to our doctors here in Kansas City and ask questions and get advice about complicated issues. Additionally, 250 smart tablets and home wireless internet devices were given to patients in rural Kansas in order for them to send health data back to their doctors in their community. They were also given a combination of devices such as a scale to weigh themselves, a glucometer to check their blood sugar, a finger pulse oximeter to check how well they're getting enough oxygen, or a blood pressure cuff to check their blood pressure, all while on their own time in the comfort and safety of their home. The hospitals and doctors are now able to continuously monitor patients with chronic conditions such as COPD, hypertension, diabetes, heart failure, and behavioral health. Local doctors are now able to call patients at their home and make changes to things such as medications and also check on their patients with much more information in their hand. And again, this was all in an effort to keep our promise to make sure Kansans have the health care they need.
Jason, thank you. Boy, that's success. It sounds like a great success story all around. What's the biggest concern right now?
Yeah, as many of you have been paying attention, the public health emergency is something that has to be enacted by our federal and state elected officials, and they can only be kind of enacted for every 90 days. And we're coming up against our last 90 days here at the end of this month. We're hearing some talk about them extending it another 90 days, but we haven't seen much movement on that at the moment. But what we are really wanting to make sure is that when the public health emergency ends, that things don't go away, that we don't have to say, yesterday we could see you in your home, but today we can't. So a lot of things are in place with us having conversations with our state and federal elected leaders. But at the same time, those are just some of the things that we're paying attention to and wanting to make sure that the great care that our doctors were giving this last year for patients at home continue to go moving forward.
Yeah, that is so important. I mean, I do a lot of telehealth in my practice, and it has been such a boon. And Dr. Newland, I know that that's been something that you championed in Wichita and other places. So why do you talk to us a little bit about the success going on in Wichita with telemedicine, and why you stopped in your busy schedule to help us talk about this important topic today?
Dr. Stites, I appreciate the chance to be here and be a part of this dialogue about telemedicine. As you're well aware, and it was just shared, the impact on the pandemic has launched something that we have wanted to have access to supply to our communities and those that we serve around us, especially towards Western Kansas, but have had limits. And then with the emergency orders, we've been able to now supply that need and have the reimbursement to make it a financially sustainable model. So it's important because of what was just shared that we feel like there's been this offering to our patients, and we don't want that to be lost. I know they are wanting to sustain this opportunity to have telemedicine. Surveys have been done that show about 80% of the Kansas population is still very interested in having this as an option in the ways to receive care. And we have a very rural state. Many people will have to drive long distances, many hours round trip to receive their care. And much care does need to be done face-to-face, hands-on. But there are times when it can be done very well through telehealth. And I think we'd love to see that continue to be available, not just in Kansas City through the KU Health System, but also through other entities like the organization I'm with Ascension Medical Group.
Yeah, that is so important. So tell us a little bit, why do you think there's this hesitation around the expansion of telemedicine in our state?
I think part of it, of course, is as any nonprofit organization as yours is and ours is, we want to serve the breadth of patients that are in our areas and that we feel a mission towards serving, and we have to though be able to do it in a sustainable fashion. We have to be able to have the reimbursement to afford the ongoing care, and we're just concerned that we again have had this made available to our patients. It's been embraced appropriately, and I feel like we are at risk of seeing that taken away from us, and we want to be able to see that sustained. I understand from the federal level there's a reasonably good chance that Medicare will continue to have some mode of continuing to offer this and have reimbursement for it. And we're just looking forward to having all of those involved in the payment models find the common ground, the right place to allow these to be sustained, which is the biggest reason it hadn't launched in a robust way before the pandemic.
You bet. Well, in telemedicine, is it a lot cheaper to deliver, or is it really about the same cost as an office visit?
I think we have to realize that there are probably a couple of different modes. I'm still a practicing pediatrician. I still have an office the kids need to come to and be seen. I still have to have appointments scheduled and people to process paperwork, you name it. And so when telemedicine is a component of a full spectrum care delivery model that includes face-to-face visits, includes therapies, includes imaging, lab work, includes hospital care. When you're part of a health system that covers all that, and telemedicine may be a few percent, 10% less even of the total package, then it doesn't really have the cost savings that may be portrayed. Now, if somebody is seeing a physician who's sitting in their couch in New Jersey who is doing nothing but this, their costs may be lower, but that's really not who you are or who we are. We are a full service salon, and therefore we have costs that are really about the same for those telemedicine visits as they are face-to-face.
Yeah, no, I think that's really an important point. And you still have to have somebody help you review the med list, get people, quote, in the room, even though you have to get them into the virtual room. There's still so much work to be done. But I'm with you, especially when you look at underserved areas who may not have an infectious disease doctor or an endocrinologist or a certain gosh, what a great tool to help make sure people get care without having to travel hundreds of miles. That just seems like a big win to me, and I'm surprised.
I would say even we could even take the distance out. As a pediatrician, I may see a child for a behavioral health issue, where in reality, the way it was at some points in the pandemic, the patient or the parent would have to go get their child from work, or leave work to go pick up their child from school or daycare, bring him to my office, and then we would have a visit across the room, both of us with masks on, and then they would take their child back to school and go back to work. They've lost 2.5 hours of time in this journey for what maybe was a 20-minute visit with masks. Now I can do them with a 20-minute commitment on the part of the parent without masks, see reactions and such, and actually have a better visit in that setting and save them time. The employers will embrace this because their own staff don't have to miss as much work for the right kind of visit.
Yeah, and I think what we're seeing at least, and I'm going to turn to Dr. Sale for a moment, is that our patients really do like telemedicine visits, but it doesn't replace face-to-face, right? You still got, we're still doing mostly face-to-face visits. I know in my practice, patients really want to come see me, but man, the telemedicine has worked out really well for people too.
Yeah, I think like you've heard already, there's a place where telehealth fits in, right? It's a tool in our toolkit. It doesn't replace all of our face-to-face visits, but it does serve as a way to allow some of our patients who have travel needs, who come from a distance, who don't want to take time off from work, who have child care needs, to still get the care they need in a time where they can't necessarily come into the office. So I think it's been people talk about outcomes and what are the benefits of healthcare via telehealth. Well, if you look over the course of the pandemic, some of those chronic disease patients, chronic long-term healthcare issues that we've been managing via telehealth have sustained and maintained those patients' health over the course of an entire year through telehealth. So I think ultimately it's been very successful in just the pandemic period. Telehealth itself goes back over 50 years in terms of its inception. It's probably been the last 20 years where we've truly seen a shift towards the internet and a shift towards the video version of that. And I think it's really been the last few probably months where it's really taken off. And we are now being able to sustain the care of our patients via telehealth in a way that is much different than we've ever been able to do before. And like you heard from Dr. Newland and Jason, we don't want to pull the rug out from underneath our patients where they've come to rely on this, because a lot of those cost savings that are out there aren't necessarily cost savings on our practice side. They're cost savings on the sides of our patients.
And the employers
Absolutely.
I mean, that's really one of the biggest things of all. So now you do a lot of telehealth and you're a surgeon. So tell us how that works. 'Cause I'm going to guess you can't kind of reach across the internet, at least not yet, and do surgery.
Right, yeah. Unfortunately, we can't do surgery over the internet yet, although with robots, there's some things you can do now. But
beam me up, Scotty. Let's go.
Right. Ultimately, I have found that there is an application for telehealth in really every practice. It doesn't, again, fit every patient type or every diagnosis. But for me as a surgeon, I can see new patients, I can see established patients, I can see pre-op patients or post-op patients. I can see some very specific disease types within my practice, whether it be allergy patients or sinus patients or chronic pain patients. All of those are things that I can do sometimes via telehealth. Again, it doesn't replace the need sometimes to see those patients in person, because before I take a patient to surgery, obviously I want to do a physical exam, and as an otolaryngologist, there are some small holes I got to look in sometimes in the ears and the nose to determine what is actually happening and whether there is a need to have an operation. So there are limitations to telehealth, but there are a lot of opportunities with it as well. It does allow me to free up some space on my schedule sometimes, where I can create an entire half day of just telehealth visits, and then create another full day of patients face-to-face who maybe have a higher acuity or a more pressing need for surgical intervention or evaluation.
How does the technology work with older folks, guys? And I'm going to classify myself as an older folk just to say I can make it work. Go ahead.
I think the idea that telehealth doesn't work for an older generation is a fallacy. I think we've seen in reality our parents, our grandparents have adopted the use of iPads, of smartphones, just to keep in contact with their families as they try and maintain their safety. So I think that has been a good bridge to then using that device for telehealth. Yes, there are some nuances to learning how to use different systems in different areas, but they have plowed through that and have done an amazing job of connecting to all of us via telehealth. In fact, I was looking at some numbers. Interestingly enough, about 70, when we look at patients who are 75 and older, there's a study that was done, or a survey by Advisory Board, and they found that 60% of patients 75 and older would prefer a virtual visit if they had to wait more than 1 day for their visit. They would actually prefer a virtual visit 75% of the time if they had to wait more than 2 weeks. And these are folks who are in that category that we think, they can't necessarily use this technology. I think that's been dispelled or debunked pretty effectively during the pandemic.
Yeah, I think that's right. I'm just going to give a shout out to my mother-in-law. Hi, Nani. How are you? 88 years old. And you know what? She can Zoom with the best of them. And I'm telling you, this thing about age, people, older folks can't do Zoom, and I don't think that's really true. Dr. Newland, I'm going to guess, you're a pediatrician, so you don't see some of the but they've got to be with some of their grandmothers or grandparents, and I bet you're seeing some folks across the age spectrum who are able to Zoom pretty effectively.
Very much so, very much so. And again, for the kids, being able to see them in their own home environment gives me an advantage of understanding the world with which they live and how that impacts their health is very valuable.
I'm glad you said that, because one of the things I found as a pulmonary CF doc is that it's been a huge win to be able to look and see people in their homes, and you can just get a sense of it. I've had a few people tell me who I can't understand their breathing very well. I say, well, can you just walk me around your house with your Zoom thing going there? And pretty soon you say, oh, wait a minute, you've got a wood-burning fireplace. You didn't mention the wood-burning fireplace. Or you see other things about that home environment that give you important information. It really does change. I think it is an incredible tool. And also, just from your role as CMO for Ascension Via Christi, you all have a strong outreach program like Kate. I mean, we're both, I think, health systems are really dedicated to working across the spectrum, not just in urban areas. So I think this is a huge win for primary care physicians in towns where they don't have specialists who can now get connected through telemedicine. Talk a little bit about your experience with that.
Right. Without a doubt, many of our rural communities could never support having these specialists live in their community. There's just not enough patient base or volume to have it warrant that level of specialization in their community. And the travel time for a physician in many of those rural areas would really forbid them being able to cope with consistency or go at the right time. The patient needs them today or tomorrow, and not when they're coming back in 3 weeks. So I think telemedicine gives that opportunity for real-time collaboration between a physician in primary care and their patient and the specialist who may reside in one of our larger urban areas, and bring that expertise to their home, to their area. It is also very supportive for these small community physicians to just have access directly to those specialists and be able to review a case and get input and wisdom to support their journey.
Yeah, I think that is so important. It's disheartening to think that we would take a step back in telemedicine because as Jason has pointed out, it really got accelerated because in the emergency acts around COVID-19, we could end up getting paid for doing telemedicine wherever people were, and if that is taken away, it is going to be a major step back, guys. I mean, I just think that's a step back for patients. Jason, thoughts about that?
I absolutely agree. I think if we go back to what we were before, I think we'll start seeing numbers back down into the 100 mark, what we were before, because you can't do this all the time and not get reimbursed. Physicians just can't do that. And so this is very important that a lot of the stuff that was put in place continues to be put in place.
Yeah, and we're not asking for a windfall, Dr. Sale, at all. This is just about making sure we can get paid for the work we do.
Right. The team commitment, like you've heard before, is the same. Whether it's the nursing support, the rooming support, the scheduling support, all of those things exist with our current telehealth visits today. They aren't different than that face-to-face visit. The only difference is whether you're in the room or not. Right. And so ultimately, the cost for us to take care of that patient is the same. And those regulatory restrictions that were in place before, the lack of reimbursement, they prevented innovation. They prevented actually good study and data collection of how telehealth can be valued as a piece of our healthcare toolkit. And now, with all of that removed, we have had tremendous innovation in healthcare, and we've reached populations of patients that we couldn't necessarily reach before. And it's, there's the social determinants of health is a big buzzword right now. And the federal government has put in place, through Health and Human Services, 50 different points that are related around patient access alone. Telehealth is that bridge to patient access that we didn't have before, that now across the region, we can provide that bridge.
Well, I just think that point that you don't have to drive an hour to get to a doctor, wait an hour or 2 hours and drive home. I mean, that wipes out a lot of a day, and then yet you can do it in just 20 or 30 minutes. That's an incredible win for patients. I wonder if that's part of the reason that 80% of Kansans in a survey recently loved telehealth.
Absolutely. I mean, there's two aspects of cost, right? There's our cost as the provider to provide a service, but there's the patient cost, which truthfully is equal or greater sometimes.
And the employer cost.
And then you add in the employer cost, you add in daycare. There are tons of what I would say maybe indirect costs that go along with that patient's visit that I think ultimately we can kind of push to the side a little bit and save our patients and our employers, the people we partner with, to drive overall cost of healthcare down in the long run, as we continue to make sure that our patients and our providers are being managed in a fair way.
And Dr. Newland, just to say, I know that I'm going to bet that you're seeing a lot less influenza and a lot less RSV. And what an advantage to be able to see kids at home and not bring them into your exam room and spread disease.
Well, I can say that our office is as clean as they come, but we are petri dishes of illnesses, as you can imagine. And so for us to be able to continue to see some of these conditions without physically coming into the location where there are a lot of other sick people would be a great advantage to have that at least as a tool, as a resource available.
Yeah, so we're driving a really good race car right now, and let's not go back to the horse and buggy age. To me, that is just so. As someone who uses telehealth and appreciates it, it would be so backwards to go back. That's just I don't know. Hawkeye, you've been doing telehealth.
Yeah, I saw a patient last week in my clinic who lives 5 hours away and was hospitalized with an intracranial device infection, meaning he's, because of Parkinson's or tremor or something of that nature, has a device to help control that disease, has an infection in that area, was hospitalized, got treatment, but still is on IV antibiotics, but lives 5 hours away. So in my clinic last week, I had a good follow-up visit with that patient. He's doing well, so it's very, very helpful.
It is incredibly helpful, and again, disappointing to think that we would be back to the horse and buggy instead of driving cars at some point. You have to be able to embrace the progress that we're seeing. Jill, let's see if there are reporter questions out there this morning.
I have a few, if there's no other reporters on the line. I'm going to start with this first one. It's actually on topic, and it's for Dr. Newland. And the question is for Dr. Newland. Has telehealth had any impact on your emergency room usage?
Well, we have seen that during the time of the pandemic, the overall emergency room utilization has gone down. As we had our shelter in home, there was hesitation to come. As a matter of fact, one of the concerns that all of us in healthcare have had to deal with is that people would be fearful of seeking care that truly is emergency care, and therefore delay the rapid interventions that are needed for some critical conditions such as heart attacks, strokes, acute surgical needs. What we have found is now at this stage where the pandemic has faded, there's still some hesitation, we understand, but our volumes have not come back up. And I think part of it is the ability of patients to access care in a variety of ways can lead them to get the right care at the right place by the right provider, rather than necessarily always seeking it through what could be the most expensive mode of care and not necessarily the best. So telehealth has given us that opportunity to sustain touch points and hopefully reduce the utilization of the emergency room. Our numbers would suggest that.
Jason, I see you shaking your head. Yes, yes, yes. Talk to me a little bit, because I know you're clearly in agreement, as am I, with Dr. Newland.
Yeah, absolutely. So, one of the several great things about telehealth is if we can see a patient in their home well before the disease progresses to they need emergency care, we know statistics show that if we can get to see a patient, put an intervention in place, we can save for every dollar you would have spent in that telehealth visit, you save $7 in an emergency to visit. That savings goes on to not only the patient, but the insurance company as well. We also, here at the health system, put in telehealth actually in our emergency department in response to the pandemic, and we're able to see many patients through that devices that we put into the emergency department in an effort to keep those patients home, and also for our physicians and everyone else in the emergency department to just keep a safe distance. So it's been incredibly impactful in the emergency department. I think a lot of people don't think you could do it in the ER, and we do it and do it well, and our physicians and patients actually really like it.
Yeah, I think it's such a win, Keith. And man, we're doing, I think we have like 5,000 visits a day ambulatory, and about 1,000 are still telehealth. So 20%, right. That's a big number. I would hesitate to make all those people come back to the hospital right now. That's just a bad idea.
Well, we're still in the midst of the pandemic, right? And so physical distancing is still important. And for those of you who've been to the clinics before in any location pre-pandemic, there were a lot of people. We had people in waiting rooms, we had staff, we have family members who come with them. And so that creates a risk during the pandemic. And telehealth has allowed us to decompress our clinics a little bit by shifting some of that volume to the virtual world and allowing us to have fewer bodies and allow us to have more space in our clinics to create that environment of safety for those folks who truly need to be physically seen in our clinics.
Yeah, a big deal. Jill, what other questions do we have out there?
Okay, Brittany with the Beacon has 3 questions that are not on this topic, but they are related to COVID. Question number 1, are there any plans for the final phase of vaccination distribution open to all people to be prioritized in any way, like by age? Do we know?
Yeah, I think it's just it's a little premature to say that right now, Hawk. Yeah. And we had this discussion yesterday. Yep. We're going to, KU, first of all, you have to follow the state guidelines and your county guidelines. And so I think that what we know today is that beginning Monday, we're going to combine phase 3 and 4 into one phase. And then after some period of time, I think they're going to go to the next phase, which that may be open. I think. Dr. Newland, any other ideas? What's your read of it, too?
Yeah, I would say that your assessment is right, that as we go through this phase 3 and 4 combined effort, I think the volume of vaccines that are coming into our state has ramped up to such a degree that it wouldn't surprise me within a month if it is basically open to any adult who is desiring it.
I'm going to guess that's right, and maybe I'm going to hope it's even sooner, maybe not. I don't know. Yeah. So much of it depends on that supply of vaccine. It's hard to predict, but I think it's coming, and I think that's going to be a great day. I think we'll all celebrate. Just want to make sure all our listeners out there get your vaccine when it's available and bring everybody you can. Become our advocates and become the advocates for everyone out there around COVID.
Good for you, and it's good for the community. So.
Yeah. Jill?
Brittany also asked, does it seem like the pandemic is in the process of ending?
Oh, is it ending? Hawkeye, do you think the pandemic's ending?
No, the short answer is no. I think, again, we are fairly content how we're doing locally, and we've always talked about the local infection dynamics. We've certainly been much better off than LA County or Houston or New York or Chicago or Detroit. We've been good, but, we understand that around the nation and in other countries, there are other surges, if you will. There are always new variants that are arising. So we don't think that the pandemic's going to be ending. A lot of people do suspect the virus will be with us, just in what capacity. We know that vaccination will help. Continuing the infection prevention measures will help. But there's no, real end to that. We just have to figure out how we can live with it best, continue to reduce the spread, continue to increase vaccination.
Dr. Newland, your thoughts about that? Pandemic over?
That is our dream, of course, but no, I would agree wholeheartedly with what was shared. I think it will become a simmer that we can live with and adjust our healthcare delivery to match that simmering levels, but hopefully have the rest of society have some normalcy come back soon. But it is all the more the impetus for all of us to get our vaccines.
I totally agree. Here we feel good. Our numbers are around 8 to 10 right now. On the other hand, about 2 weeks ago, the numbers in Kansas City were about 85 or 90 a day. Now they're up to 130 a day. So that would push us up to that 15 to 20 range. And so if after the spring break people come back and people go out, their restaurants, and suddenly the daily number in Kansas City is 200 or 300, well, we're going to be about 30 patients a day. I mean, it all tracks back to how many people are getting the infection. And how do you get the infection? You don't practice the rules of infection control. I mean, it always comes back to the same story. So I don't think we're done yet, but we can keep it, to your point, I love that term, simmer, and that allows us to be a lot more normal. And we get vaccinated, we're back at Chiefs Stadium, rooting on the Mahomes and the Chiefs. We're back at Royal Stadium saying, let's go Royals. Or, of course, the Cauldron back at Sporting.
Right.
Talk about a loud crowd. That is a lot of fun.
Brittany has one more question, and her final question for the Beacon is, do I need to bring a note from my doctor detailing my medical condition to receive the vaccine?
So we don't really know the official part of that yet. That's not been released by the state, but I think that's not going to be the case, and I don't think we're going to require that here at KU. I think we're going to go on personal responsibility that you're going to tell the truth and be honest and fair about it. Dr. Newland, how are you thinking that things are going to go to Wichita?
Yeah, our experience is, of course, our county is guiding and inputting the wisdom into how this gets lived out. And they have relaxed some of that micromanagement mindset to allow some freedom to just get shots in arms using those guidance. So I agree. I doubt that there'll be that level of scrutiny. We just need to keep those vaccine clinics filled.
Jill.
Right, let's move over to some community questions real quick. Cindy wants to know, can you do telehealth with urgent care?
Keith, we've been doing some of that.
We have been, and I think, Jason, you showed that great graph early on. It's probably been 5 or 6 months now since we opened up our urgent care via telehealth. And so, yes, we've been very effective in meeting our patients' needs via telehealth with urgent care concerns or questions.
Jason?
Exactly. Our urgent care has been open since June. You just go into your MyChart account and navigate to, I think it's a stethoscope icon, and then you're asked a few questions and you get right in line to see a physician. Typically, we see the wait is about a minute or two. Sometimes it's a little busy. I think sometimes the wait is up to 10 minutes, but yeah, you can absolutely do that right now.
A 10-minute wait when we're busy. Yeah. Dr. Newland, how's it going in Wichita as far as telehealth?
Yeah, I think for us, I would probably want to reinforce that for those patients who have primary care physicians, and we really would embrace, as you would, that every patient has a physician that they can claim as their go-to person, that many of them are offering telehealth visits just for those same things that an urgent care site could help with. So take advantage if you have that relationship to utilize it. And then as you've shared, there are resources for those who don't have a primary care physician to go to in those settings.
I think that's a great point. Always turn to your PCP first. Jill.
Mary asks, are there Kansas state laws that need to be amended or new state laws required to keep the current level of telehealth services in place? She wants to know what needs to happen.
Jason.
Working with state officials to actually do that. We do need some laws changed in our state. Back in 2018, we had some laws enacted, but it didn't go far enough. And as you can see, even in 2018, our numbers were very low in the state for telehealth visits. It didn't free up a lot of funding, and it didn't free up a lot of things that were barriers in terms of just even being able to see a patient in their house was not allowed in those laws that were enacted in 2018. And so a patient still had to get in their car and go to a medical facility to still be seen in the state of Kansas. And so, yeah, there's a lot of work that needs to be done in order to change some laws here in the state of Kansas to do what we're doing right now under the Emergency Act.
Okay.
Yeah, I think
Ronnie has. Oh, sorry.
Go ahead, Keith.
Okay, I was saying a big part of that too is legislation that impacts finding like that middle ground, as Dr. Newland said, around reimbursement for telehealth as well, right? And so not only is it removing the regulatory restrictions and the impact that had on slowing the growth of telehealth, but it's making sure that our physicians and our providers are reimbursed for that service across the spectrum of care.
And again, we're not trying to say give us a whole bunch of extra money. We're just trying to say we got to make sure we have our costs, and because there is a cost to telemedicine, you still have to have somebody check you into the telemedicine visit. You still have to have the assessment. You still got to spend time on the phone with them. You still got to go do follow up. I mean, there are costs around it, and those costs are real. Not to mention, Jason, just the technology cost.
Yeah.
Yeah, exactly. Yeah, technology isn't free, and licensing, both for the equipment that we use and also licensing just actually for the physician to get on it, that is actually quite expensive. And the reason why is because it's very different than if you were to log on to Zoom right now. All of the stuff that we use keeps your connection to the patient private. It's encrypted, it's HIPAA protected, and there's actually a very higher level of expense to maintaining and making sure all of that conversation that you have with the patient is secure and safe.
Yeah, that is
the same level of service you get face to face. It truly is, and I think that's what he's talking about.
Yeah, maybe the stethoscopes are a little cheaper, but other than that, at least now, soon enough on your smartphone, man, you're going to be doing your ultrasound online.
You can check your heart rate.
Yeah, it's all there.
Yeah,
all right, Jill, one more question.
No, we're going to do 2 more telehealth questions, and then I've got one for Dana Hawkinson. You guys are doing good, but we're going to hang in there for just a sec. Shirley wants to know,
you know who the boss is.
I know. You love me, but you know you do.
I do.
Okay. Shirley wants to know, are the telehealth open 24 hours?
Keith?
So, yeah, that's a great question. Right now, our telehealth visits are not 24/7. They tend to mirror our clinic hours. We do have our urgent care hours that are extended and typically run 7 to 7, and in some days 7 to 9.
Dr. Newland, Wichita.
Yeah, I would say ours also mirror the clinic environment. And again, there are probably resources out there that are designed for urgent care 24/7. But again, it's not with your own private relationship with your PCP. And we do value that. And I think a lot of good decision making when it comes to healthcare needs is based on a relationship and knowing the patient, knowing their personality and needs, their chronic conditions. And so I think as telehealth becomes an ongoing phenomenon, I think we will see expansion of those hours into the evenings and into weekends to a greater degree.
Jason, I see you nodding your head.
Oh, sorry.
We've done a lot of research as to kind of demand for telehealth. And so what we see is a lot of this is scheduled, right? When you normally come into the office, you've scheduled those visits. Our on demand, or I want to see a doctor now, is typically mirrored exactly when the urgent care is from 7 a.m. to 7 p.m. or 7 a.m. to 9 p.m. Excuse me. We've actually gone out and asked other hospitals across the nation who have done 24-hour care and actually have stopped doing it because they just don't see anyone in the middle of the night. And so right now, that's kind of how we're doing it here at the health system.
Jill.
Last telehealth question for today is, are there guardrails in place in MyChart or whatever communication device you're using with your doctor to filter out what is or isn't appropriate for a telehealth visit?
Dr. Sale?
Yes, so we do have a lot of those pieces in place. And so as we go through this process, and our schedulers have a script to go through to talk with patients about things that they want to be seen for. Again, most things we can discuss with our scheduling process, and if there are reasons not to see them, emergencies, urgent situations, then we tend to divert those patients to our face-to-face clinic. We've had the same thing with folks who are COVID positive or have COVID-like symptoms. We screen those patients, ask them their travel questions, and then divert them to telehealth as opposed to face-to-face. And so we do some of that screening up front. There are not necessarily hard and fast criteria that every patient has to go through to get a telehealth visit. Most of them are by specialty and by specific patient type. And so we've asked our physicians to really kind of weigh in on what things are most amenable to telehealth. And so we really haven't opened telehealth to every patient condition that exists. In fact, we try and limit it to ones that are most amenable to telehealth, and most of that is done with physician guidance and their schedulers. Dr.
Newland, same process?
Exactly, yes. Our physician offices guide those and have their protocols in place. And again, with this concept of the patient needs to get the right care by the right individual at the right location at the right cost. And all of those components have that right place in telehealth. And so it is at the local level with physician preference, and also the guardrail that the same level of service has to be provided. You have to match what would be taking place face to face.
Yeah, I think that is so important. And I think the other part of it is you weigh against that the patient's ability to get there. Because even if all the signs may point to in-person visit, but if a patient simply can't get there, has to travel too far, has too many complications with childcare, et cetera, you can still do a telehealth visit, which most of the time is a lot better than nothing.
Even weather alone has been an impact, right?
Yeah,
we've had some of the snowstorms that have come through, and patients can't physically make it to clinic because of the challenges on the roads. You'll be able to convert some of those to telehealth and still complete that patient's care.
Okay, last question, but I want to tell the panel that you're getting really good reviews today from Facebook. They're thanking you for the information that you're sharing, and they really are enjoying this. And Jan, Michelle, and Kitty, great questions. I'm going to put them on tomorrow, I promise. But Dr. Hawkinson, please help Caitlin. She writes, getting my second vaccine today, but I got no sleep because I'm so anxious. Should I wait? Is it safe for me to go ahead and get the shot?
Yeah, I would be concerned with what your anxiety is about. Is it just about getting the second dose? Overall, the answer is yes, get your second dose. If you're scheduled to get it, get it. Within about 2 weeks, you'll have optimal protection. Again, the side effects of that second dose are variable. Some people have a little bit worse side effects from the first one, meaning a little bit more shoulder pain, maybe a little bit more fatigue. But then other people also have had no side effects, even though they had side effects with the first dose. So absolutely go get your second dose if that's all it is some anxiety. And again, I don't know what the anxiety about. Is it about the shot, or is it something else in your life? But go ahead and get that second dose. And
I'll just say, I think all of us probably in this panel have had 2 doses of a vaccine. And, I got I wasn't here one day because the second, but, it lasted for 12 to 24 hours, and it was so much better. And I was fine. So. Did you?
Yeah, I had a little bit of chills the night I got the dose. I went 12 hours after I got it, got some chills that night. Next day, it was fine.
Hawk?
Yeah, just a little bit of shoulder soreness and a little bit of fatigue that next day. But
young guys. Dr. Newland, how was your second shot?
My first shot, I had just a little lightheaded, blah feeling. My second one, virtually nothing.
That's
so
awesome.
I told her to go for it.
Absolutely.
Jason Grunstrom, how was your second shot?
Yeah, same thing. I just had a little arm pain and woke up the next morning with a headache. And the moment I stood up and drank some water, I was fine the rest of the day.
All right. See, everybody's a little bit different. I guess I was a sickie, but you know what? I would absolutely get that second shot again without hesitation. I look forward to the day I get my booster. Hey, tomorrow we're going to have Amanda Cackler as the Director of Infection Prevention and Control here at the health system. She'll be joining us to answer all your questions. We do our top 10 list with all the top 10 questions or 12 questions, however many there are, and we look forward to that. That'll be a great program, and that is a special day. We had our 250th celebration yesterday, but tomorrow, March 19th, is exactly 365 days since our first episode of the Morning Media Update. So that is the official 1-year anniversary. And who better to celebrate that than with Hawkeye and Amanda, who's been with us since the start. Team, final thoughts. Dr. Newland, I'm going to start with you.
No, I just appreciate the chance to be a part of this dialogue and help support all of us being able to serve our state in a robust way, including this as a tool.
Yeah, thank you so much for being on the program. Really appreciate having your voice from Wichita and knowing what a great position and great job you do down there. So thank you very much for being a part of our program. Jason Grunstrom, final thought?
I'd echo the same thing. I really want to celebrate the doctors and nurses throughout the state of Kansas who have done this incredible work with making sure that our patients are connected for telehealth. And I really want to keep the momentum going. So, thank you for having me on and being able to share with you all the stuff that we've done.
Keith Sale.
Yeah, again, like everybody said, thanks for allowing me to be here and share this. I think if nothing else, the pandemic has highlighted the value that telehealth offers our patients and our medical teams to provide care at a high level, consistently, and safely. So I really think it's important that we try and maintain this tool in our toolkit and really actually help it grow and continue to push for more innovation and even improvements in telehealth. We talk about remote monitoring and other things. There is more to telehealth and there is more to digital healthcare than just a video visit. And I think if we shut it down now, we really lose the opportunity to really expand healthcare in a new and fun way.
Yeah, there was a question about vaccination criteria. Moving forward within these next few weeks, we really do hope that there's going to be enough supply where people are able to walk into their health system or a private pharmacy or other county mass vaccination sites to be able to get vaccinated. And we will continue to give the message of supporting that. We know that these vaccines are safe and efficacious. So we will continue to give that message and hopefully reduce vaccine hesitancy and be able to get everybody vaccinated, because overall that will help the general population. That will help us return to normalcy, as we talked about earlier in the program as well.
Pandemics are hard, and it's important to find silver linings and things, and we've all experienced how difficult they are. What I would urge you to do is, if you know people who are talking about telemedicine with representatives, et cetera, let them know how you feel, because it is really an important thing. I can't imagine taking it away. It has been just a blessing to have it available, and to think that we would take that away would be like saying we're not going to do CAT scans and MRIs because they threaten radiology, or because we're just say we don't want to use vaccinations because gosh, it could threaten your immune system. I mean, you just look at that, you think about the sheer logic of it, and you're like, do you understand how wrong that is? Telemedicine is one of the most important tools, and if we don't keep going down this journey, we're going to ignore our ability to reach out and touch people, because along the other side of the telemedicine development are the smart tools that are going to be going along and complementing it. This is an important tool for your health, and our ability to do that is based upon the legislation that allows us to see patients anywhere, anytime through telemedicine. Take that away, and we are taking a huge step back on our ability to help Kansans. We hope we can gain your support. We want to thank you very much for being a part of this program today. We'll be back with you tomorrow. And remember, especially in the age of telemedicine, there's still no place like home. We'll see you tomorrow.